I've discovered a movement in the medical field called deprescribing, and it applies to statins as well as a lot of other maintenance drugs. So let's take a look and see what that's really about. Stay tuned. We're going to actually set the topic of statins aside for a moment, and we're just going to look at a headline from my past. It's something that I read many years ago in a state that I was living in, and it was, Governor appoints panel to address insurance fraud. The goal was to reduce fraud instances by a certain percentage by a certain year. And when I first read this, I actually got very excited because I saw insurance fraud as being a big problem. Insurance companies were defrauding their customers all the time. Delayed claims, denied claims, undervalued claims. And when I read the article, I was a little disappointed to discover that I had it all wrong. The panel's charter was not to reduce fraud by insurance companies perpetrated on consumers. It was to reduce the instances of consumers fraudulently making claims against insurance companies. Now, that is a problem, and that affects all of us honest people who don't make such claims, because we end up with higher premiums if those fraudulent claims are paid because they're undetected or not realized that they're fraud. So yeah, this is a legitimate thing to look at, but at the same time, they missed what I consider the far more prevalent problem, and more important problem to deal with. So we're going to just keep that in mind because it's going to be an analogy here. So I found this term, to drive to deprescribe, and this is how I found it. In an article got from the AARP, taking multiple medications, beware of side effects. Nearly half of older adults take at least 5 drugs, and the side effects can add up. And in the article was the first mention I had seen of this deprescribing movement in the medical community. So I searched around. I found a bunch of other studies of this kind. For example, Quality Improvement Project. And there will be links in the description for all of this. Just deprescribing statins in patients over 85 years old. In the Journal of the American Medical Association, or the JAMA, cardiovascular outcomes and mortality associated with discontinuing statins in older patients receiving polypharmacy. Then also from the JAMA, evidence-based deprescribing of statins in patients with advanced illness. What do we see here? Well, I think what we see is that this drive to deprescribe is not saying let's look at healthy people and see if they really ought to be on statins. It's looking at older people, people at end of life. Let's explore that a little more. But before I go on, I just want to do a little bit of a sidebar here. In the U.S. Deprescribing Research Network website, they had an article there, and deep in the article, there was a mention of a rebound effect. Now, if you watched my video on gaslighting that sometimes our doctors do to us, I mentioned an incident where I had asked my doctor if there was such a thing as a rebound effect, and I got poo-pooed. It was like disrespectfully just blown off. Now I discovered that there is such a thing. Unfortunately, this wasn't an academic article, so there were no references, so I couldn't actually find the preclinical studies, but I can believe there is such a thing. This is just a lesson that we can ask intelligent questions of our doctors, and we shouldn't accept just a simple, no, that doesn't occur, when you can tell the doctor hasn't even thought about that. So looking at those article headlines, the common thread among all of them is people who are very old, or if they have advanced illnesses, probably do not have a very lengthy life expectancy ahead of them. So if we're going to understand the deprescriber's point of view, let's think of what their thought processes are. We don't necessarily agree with these thoughts, probably agree with some of them, but let's at least understand them so that we can understand where they're coming from. First of all, we have a doctor who's faced with the decision of whether to deprescribe a statin. First of all, he believes that statins offer great benefits. We're going to go with it. We're going to accept that because that's his thought process. He's also must be believing that the patient is beyond the help offered by the medication. What does that mean? Well, that means if you're faced with being deprescribed, the doctor's saying, you don't have much time left. Let's get you off this medication. There can be an increased quality of life as a possible outcome of deprescribing. And I don't see how that could tie directly to necessarily just patients who have a limited lifespan ahead of them. Really ought to apply to everybody. So we should always be keeping that in mind. If doctors aren't deprescribing statins, even though they believe that your quality of life may be increased, that means they're making a decision for you. They're making a value judgment for you that the benefit that they think you're getting outweighs the decrease in quality of life. And then finally, they feel that polypharmacy, which means taking more than one drug, usually more than one maintenance drug, people take sometimes 10, 15 different maintenance drugs, that's complicating matters. Well, yeah, I don't see how it couldn't. So I searched around for some deprescribing guidelines, and I found a lot of them, and one that I'm going to review here is actually from the Primary Health Network of Tasmania. Now, I didn't pick a Tasmanian one to be obscure or anything. It was actually very well done, and I think it's worth going over. First, some of their key points. Statins are effective for secondary prevention, though there's no studies for people over age 80. The annualized numbers needed to treat, in other words, this is how many people we would have to treat in order to save one from having a heart attack, and those are in the 50 to 80 range. Now, that's a per year thing. I really would prefer them to put numbers needed to treat in terms of some span of time, such as 10 years, and we should always speak of risks in terms of 10 years, because if we start mixing time frames, it gets very confusing and it's hard to compare the two. In this case, okay, 50 to 80 range for a year, maybe when you're talking about people who are 80 years old, maybe it's fairer to look at 1 year at a time. Statins are considerably less effective for primary prevention. Annualized numbers more in the order of 150 to 300 for people over 65. Probably the younger, like somebody who just turned 65, their number needed to treat for the next year would be 300. In other words, we're going to put 300 people on a medication to prevent one heart attack. So those numbers basically say primary prevention in older adults, it's just not very effective. The mortality benefit of statins is diminished if non-cardiovascular mortality is high. In other words, if you have cancer or you have COPD or you have some kind of life-limiting illness, what's the point in trying to avoid a heart attack when something else is going to get you in the meantime? This is all very kind of negative, but that's the thought process. And then adverse effects are related to dose and more frequent in patients with polypharmacy. Again, backs up what I'd said earlier. I looked through this, it was kind of like a brochure sort of thing, and this is another one that's a little off topic, but I really want to go over it because it was in here and it's something else that I've talked about. Impact on memory. Observational data from a post hoc analysis of the ASPRI, was an aspirin-based clinical trial, found no difference between statin users and non-statin users. Okay, so this trial wasn't actually about statin users, but the data was there. They know who was taking statins, who wasn't. And they're claiming that for instances of dementia, that there was no difference. And then they said, well, the hazard ratio is 1.16. If there was no difference, the hazard ratio would be 1. And the 95% confidence interval ranges from a 0.97 hazard ratio up to a 1.4. It is true that this would not pass the rigid criteria for statistical significance if this were to be published to say that statins are very likely to cause dementia. But it's not, there was no difference. They found a difference. It didn't quite meet that 95% criteria. For it to meet the 95% criteria, both the figures and the confidence interval there would have to be over 1. It's almost 1 on the lower end, and it's way over on the higher end. So this is not no difference. This is far more likely than not that the statin users in the trial had a higher incidence of dementia due to the statins, though it didn't meet the 95% certainty threshold, so we wouldn't want to say it's definitely the case, but it is far more likely than not. And then when we look on mild cognitive impairment, you'll see that the confidence interval is actually centered around 1, practically right on 1. In that case, I guess I would argue that it's very hard to detect mild cognitive impairment. You've got a population here of elderly patients. It's really hard to compare one to another. If there was a mild cognitive impairment for somebody at 80, would we really detect it necessarily? Could we compare it to somebody who's 100 and detect it? The mild cognitive impairment, it just needs a really intensive study to determine if it's really there or not. So in this deprescribing criteria, in favor of deprescribing was if there was a short estimated life expectancy. Randomized trial of discontinuing statin therapy in patients with life-limiting illness suggested that it was not only was it safe, but an improved quality of life. There's that quality of life thing, and that's where that came from. Poor overall functional status. You've got so many other problems. This isn't going to benefit you as much. It's not relevant. This is actually a sad thing to be telling a patient, because if the doctor really believes that the statin is helping, we're just putting ourselves in the doctor's position and trying to understand where he's coming from. He's basically saying, it's hopeless, go off and die. If you have a low cardiovascular event risk, well, patients with lower risk have lower absolute benefits from statins. Well, I think that's pretty obvious. But again, they're talking older patients or the presence of suspected adverse effects. My feeling is there's a lot of adverse effects that aren't suspected. We should always be looking for them. These are the reasons they may deprescribe statins, but again, in the context of older patients. Well, what were the criteria against deprescribing? Patients who are well and functionally independent and have a reasonable life expectancy may derive ongoing benefit from the use of statins for secondary prevention. And also, it doesn't say primary prevention. My position on this channel always has been I really don't touch secondary prevention too much. I can imagine that there are reasons that statins may actually help in secondary prevention. If somebody's in secondary prevention and they have a good outlook otherwise, they might want to consider not deprescribing. In patients with a very high risk of recurrent events, a recent acute coronary syndrome, that's what ACS is, ischemic stroke, severe peripheral artery disease, coexisting poorly controlled diabetes. Statins probably contributing to that. Yet they're saying that's a reason to keep them on statins. Severe renal dysfunction, kidney dysfunction, that can also be caused by statins. Yet they're saying these are reasons not to take them off statins. And the point about Aboriginal or Torres Strait Islanders, there's probably some kind of genetic thing there. Remember, this is a Tasmanian criteria, and they probably know about the populations there. So they're saying all these should be considered for ongoing statin therapy. Poorly controlled diabetes, severe renal dysfunction, and you're going to keep them on statins? I don't get it. So what's the conclusions from all this? Well, like our insurance example where they've only addressing half of the problem, I think they've missed the great opportunity here to talk about deprescribing for other people. So the deprescribing movement is geared towards patients in end-of-life and near end-of-life conditions. We're going to make you comfortable and we're going to take the drugs away from you and see if you perk up. It assumes the statin benefits are real and substantial in other circumstances. And I think that's a false assumption. I think this deprescribing movement should be applied to people at all different ages and all different levels of health. It's currently not a useful movement to point to for support of getting off or not starting statins for most of us. Most of us who go to our primary care physician, we can't say, hey, there's a deprescribing movement. Well, no, the deprescribing movement is for people who are in end-of-life conditions where they basically said the benefit's no longer there. And if your doctor is convinced that there is benefit for you, well, then you've got to make other arguments against it. But it could be useful for getting elderly relatives off statins. What you're telling patient, if the elderly relative is actually sharp enough to understand what's going on, the message they're getting there is, Uncle Bud, kind of getting up there in years, you're kind of getting to end of life. Why don't you just forego this measure for now, because maybe you'll feel a little better in your last few years. That's a tough message to deliver, but it is the message that's there. So that's what I've got on this topic. If you appreciate this content, please like, share, subscribe, and comment on this topic or others you'd like me to cover. And if you haven't seen this video, I recommend you take a look at it now. Thanks for listening.